fight, but oh well, note to self, 4 pints in, you're someone else. If you can't see my mirrors, then I can't see you. So don't say you won't forgive me, 'cause you always do. At least you say you do. It's funny how when it's upside down, I push through, I just put up with you. Okay, don't be smart. Who do you think you are? With your earring, walking tall, doing your best to make me feel small. If you can't see my mirrors, then I can't see you. So don't say you won't forgive me, 'cause you always do. At least you say you do. It's funny how when it's upside down, I push through, I just put up with you. Okay, love you, bye. Okay, love you, bye. Okay, love you, bye. Oh well, note to self, 4 pints in, I'm someone else. But you're no angel, please. So could you just put up with me? If you can't see my mirrors, then I can't see you. So don't say you won't forgive me, 'cause you always do. At least you say you do. It's funny how when it's upside down, I push through, I just put up with you. I just put up with you. I just put up with you.
Every time I say what's on my mind, it never really seemed to
till my legs go numb. Till I go numb. Dizzy till my legs go numb. Till I go numb. Baby, it's 4:30 and my whole world is upside down. I can't help but wish that you were here with me right now. These nights are rolling over me. That's not how it's supposed to be. Yeah, I can't stop thinking about you. Yeah, my body forgot how to move. Girl, you took the most of me. I'll just keep on drinking till the sun comes up. Get the feeling like I need your love. Dancing till my legs go numb. Till I go numb. Dancing till my legs go numb. Till I go numb. Dancing till my legs go numb. Till I go numb. Dancing till my legs go numb. Till I go numb. Dancing till my legs go numb. Till I go numb. Dancing till my legs go numb. Dancing till my legs go numb. I feel your love. I feel time is up. When I was a child, I never knew enough what that do to me. The wave of love is a transient hug. The water's the shell and we are the nut. But I saw a hand arch out of the barrel. Look at all the peaches. How do you celebrate? You can't appearance out of nowhere. It's already dead. I know you have the dove. I'm not getting wet. Looks like a date is set. Show the ferret to the egg. I'm not getting let along. You shook at the ivory mantle. As a poet I knew to be gentle. When you have a child, so begins the braiding. And in that braid you stay. Look at all the peaches. I want to celebrate. I can appearance out of nowhere. It's already dead. I know you have the dove. I'm not getting wet. Looks like a date is set. Show the ferret to the egg. I'm not getting let along. The wave of love is a transient hut. Water's the shell and we are the nut. But I saw a match struck outside the barrel. It's already Show the ferret to the egg, I'm not getting let alone. The barrel, it's already dead. I know you have the dove, I'm not getting wet. The barrel, looks like a date is set. Show the ferret to the egg, I'm not getting let alone.
Good afternoon, thanks for coming. And we certainly appreciate people who have moved forward because it does help. My name's Michael Moore. I'm the current chair of a global task force on immunisation for the World Federation of Public Health Associations, and I'm a past president of that World Federation. I have a background as a politician. I was a Minister for Health and in fact Australia's first independent Minister in the Australian Capital Territory, and I have a PhD in public health advocacy. So today we are going to have the session introduced by Cassandra Hall-Murray, but before we do, it's my pleasure to acknowledge that we're on the land of the Turrbal and Yagara peoples, and it's my pleasure to express our appreciation for their ongoing culture and connection to the land. Personally, I live and work on the land of the Ngunnawal people in Canberra, and I'd like to express to them as well my appreciation for their connection to the land and pay my respects to their elders, past, present, and emerging. I think it's an important, really important thing for us to do at this conference at this moment, when in Australia we are considering whether or not we are going to give a particular voice to Indigenous people in this country. And I would encourage everybody to vote yes, to support that voice, to support Indigenous people here, and also to support the health outcomes of Indigenous people internationally. It's now my pleasure to hand over to Cassandra Hall-Murray.
First step completed, I did not trip. So, thank you, Michael, and thank you all in attendance today. We really appreciate it. On behalf of Pfizer, I would also like to thank FIP for allowing us to sponsor this symposium today. Excuse me. My name is Cassandra Hall-Murray, and I'm a Senior Medical Director and Team Lead within our Vaccines Global Medical Affairs Group at Pfizer. But more than that, I'm also a very proud pharmacist licensed in the United States in my home state of Pennsylvania. So, green button goes. This is our agenda for today. As you can see, we have a number of sessions, and then we will follow that up with a question and answer session, hoping that you all participate in that. I'm joined by our esteemed speakers over here. The first one needs no introduction. I think you're all very aware of who Dr. Catherine Duggan is and what she does. We also have Professor Lisa Nissen here with us. She is the director of the research program at the University of Queensland, right here. And then, of course, Professor Michael Moore, AM, who just did a lovely introduction of himself. So my first session here will be protecting older adults against the burden of vaccine-preventable respiratory diseases. So I don't know how many times we need to reiterate it, but I don't think we can say it enough. Community pharmacists play a critical role in meeting the public health needs of their communities. We know what an immense impact pharmacists had in protecting their local populations during the COVID-19 pandemic. As we've heard multiple times, pharmacies kept the doors open while others turned the lights off. We are a trusted, accessible, and highly skilled set of healthcare practitioners, and with a unique ability to offer a simplified patient journey when it comes to immunization that will hopefully grow vaccine uptake as well as help build resiliency into our healthcare systems. So although we've made tremendous gains with regard to immunization in the last couple years, really fueled by the COVID-19 pandemic, there are still gaps and opportunities that remain to continue to expand the role of pharmacists. So there's a lot on this slide, but basically what it's telling us that, within the community pharmacy, we are able to introduce and scale up vaccination at an incredible pace following the approval of COVID-19 vaccines. And in 2021, pharmacists across the world made significant contributions to the rollout of COVID-19 vaccines. We have more than 35 countries now that allow pharmacists to vaccinate. And more than 25 countries allow pharmacists to vaccinate against COVID-19 with over 390 million estimated doses of COVID-19 vaccines administered by pharmacists. That is huge, and we can't underestimate what the public health benefit of that has been. There are 8 countries that have permitted pharmacists to vaccinate for the first time in 2021, among those including Italy, Germany, Belgium, and Poland. But we still have gaps because, as we know, COVID-19 is not the only vaccine-preventable respiratory disease. We have other vaccines available for adults. Right now, we only have about 15 countries that permit pharmacists to vaccinate adult patients against pneumococcal disease. So there's still work to be done. We also know that right now we have suboptimal rates of vaccination for older adults. Despite what we've had such a focus on adult vaccination during the pandemic and generally high levels of COVID-19 vaccination for those individuals at risk. Other than that, our vaccine uptake levels remain really suboptimal. The graph below here shows us the disparity between COVID-19 primary dose vaccine uptake rates in those individuals 60 and older compared to influenza vaccine uptake in those individuals 65 and older across 4 European countries. And you can see that we've done a decent job with COVID-19, but for our established vaccine like influenza, we are not seeing the uptake that we need. And keep in mind that the WHO target is 75%, and we've seen that happen in about 1 country so far. So the other gap that we have is that we have missing data on vaccine uptake for other vaccines. Notably, we really don't know what the level of adult pneumococcal vaccination is because we have limited data, so it's really difficult to understand the current unmet need with regard to something like pneumococcal vaccination. So where does community pharmacy fit with regarding to expanding healthcare system capacity? We know that there's huge potential there to support and increase vaccine immunization uptake. So the COVID-19 pandemic has emphasized the need for a formalized adult immunization schedule such as what we see for pediatric vaccines, and also the need for additional complementary capacity within our healthcare systems because we know that our systems are already overburdened. We've seen a ton of burnout related to the pandemic. We've seen other healthcare professionals leaving their professions, again, leaving us with systems that are really precariously set up for, if God forbid we are ever to see another pandemic, but even beyond that, just surges in other diseases. So expanding the role of highly skilled frontline healthcare workers, such as pharmacists, can help us ease some of that burden on additional healthcare workers, as well as the system overall. Additionally, increasing the number of available vaccinators can also help us to improve adequate delivery of vaccination programs. I mean, a program is no good if the vaccines don't get into someone's arm. Community pharmacy is, of course, incredibly well placed to support adult and older populations, as these are the individuals that are seen most frequently within pharmacy, helping to meet the broader population needs for immunization across the life course. And we'll talk a good bit about life course vaccination. So speaking of life course vaccination, vaccination is not just for children only. You know, we know that the primary focus of most vaccination programs has been towards childhood immunizations, rightfully so, and we understand the reasons why. However, we are just continuing to build the number of vaccines that are available for adults, and with chronic disease primarily being the focus in the past, and we really need to switch that emphasis to preventing disease across everyone who is eligible for vaccines. With all of that, though, I will iterate one more time, we have generally low vaccine coverage for routinely recommended vaccines for adults, and thus there is an urgent need to address the problem of adult immunization. So when we think about who to vaccinate, it's also who is most at risk, and I think this slide illustrates this well. You know, when you look at respiratory diseases, the risk of death itself increases exponentially the older someone gets. And if you look here to the right, you can see a number of infectious diseases, including influenza. And adults who are 60 years of age have a 10 times greater risk from influenza, death from influenza rather, than those who are 20. That's not surprising, but I think what is surprising is just how that risk grows exponentially. And one way to tackle this risk is to increase the rates of vaccination against influenza, which also helps to reduce the disease severity, as well as the rate of other routinely recommended vaccines, particularly against vaccine-preventable respiratory diseases. As we speak of vaccine-preventable respiratory diseases, some of us are coming out of our winter season, some of us are going into our winter season. I'm from the Northern Hemisphere. We're getting ready for all of this good fun. So when we're managing multiple respiratory diseases, we know that those surges can really put a strain on our healthcare systems. And the graph on the left shows you COVID-19, influenza, and RSV detection in primary care sentinel source specimens by week in the WHO European region, and this is early this year. You can see the spikes in disease towards the far right of the graph, with influenza leading the way, but also you can see that RSV was actually isolated more than COVID-19 was, And all of these respiratory diseases as a bundle really contribute to severe illness and to high levels of hospitalization in vulnerable patients every year. And this, again, is where we see that strain being put on our already vulnerable healthcare systems. So as we are moving out of emergency mode, we need to really think about how do we manage COVID-19 vaccination along vaccinations for other infectious diseases. We saw a pretty dramatic drop overall in the rates of vaccination for other vaccine-preventable diseases, starting with the COVID-19 pandemic, and we have not caught up yet. So there remains a lot that needs to be done. However, in order to improve vaccination rates and ensure that the value of vaccinating older adults against these vaccine-preventable respiratory diseases is acknowledged, we have to improve vaccination rates so that we can alleviate the pressure on healthcare systems. And also to be able to protect our aging population. As we know, we've all seen the graphs. We're just getting older and older, and sure, I feel that. Across respiratory diseases, we need also better vaccine monitoring systems. We really don't have a great handle on what the true uptake of vaccines are for our older adult populations. Doing this can help support actually increasing our goals for vaccination. Because if you look across, different vaccine goals, our uptake goals, we expect a lot more for pediatric uptake rates versus adults. And sometimes we have to sit and think, why is that? So more work to do on that. Now that we're looking at, modified booster doses for COVID-19, we need to think about how are we going to get those booster doses into the patient populations for which they're recommended. And if you look in the middle of this slide here, the box in the middle, you can see the Australian COVID-19 booster rates for the previous 6 months. And what we see is really less than what we would hope for, with the most vulnerable population in the 65 and older cohort being at about 38% uptake of booster doses. And that's really a lot less than we want and need in order to continue to maintain healthy populations. And it's not just Australia, of course. If you look to the far right for that graphic, that is the median cumulative vaccine uptake among adults 60 and older in EU countries for up to, as of rather, June of 2023, so June of this year. You can see really good uptake for at least one dose or the primary series, as well as second dose, but then when you get in, for the first dose. But when you get into the second and third boosters, you see abysmally low uptake. So what do we really need to keep in mind? I think for pharmacists, one thing to really remember is that every patient touch point matters. And there are the 4 R's that we have listed here with regard to how to continue to prioritize vaccination within your own practices. Strongly recommend vaccines during each encounter. Repeat that recommendation at each visit with your patient. Remind your patients that it is time for their vaccines, and then review vaccine recommendations with your patient to ensure that they have received the recommended vaccines rather. Your patients trust you, and so your recommendations really do matter. And with that, I am going to turn it over to Dr. Catherine Duggan, who is going to present on the new paradigm in pharmacy vaccination services. Thank you.
Thank you so much for that welcome, and welcome everyone to this session. It gives me great pleasure to be here with you today, and I'm pretty sure that most of you know who I am, and if you don't, we'll have a word later. Chief Exec of FIP is literally the best job in the world. Not only can you bring your professional acumen to play in every part of your working day and night, because it's always a day or a night somewhere, you can also see your profession grow, flourish, share, nurture, and enable each other. Before I get going on the presentation, I just wanted to say a couple of things about big picture. If you think about the vision for FIP, where everyone in the world should have access to safe, affordable, effective medicines, you know that we're not there. So if ever there was a time for an FIP, I would say it's now. The big picture for us is alignment with global health. It's alignment with what ministries need and want, but that's through our profession, whether it's pharmacists, pharmaceutical scientists, the pharmacy workforce, or our educators. The big deal around the development goals that we've developed, aligning them to the SDGs, is the goals that focus on equity, access, safety, and sustainability. All the others are very important as well, but without equitable access, without safe and sustainable services, we're not going to achieve our aims. And then also, there's a way in which FIP can do this is through case studies, toolkits, advocacy, but the biggest, most powerful engine for change is taking examples from countries that have done something and showcasing that to countries that may be struggling to do something. So that's really the background to the presentation. We are a non-governmental organisation founded in 1912, and for any of you who don't know this, our birthday was yesterday. That's why it's World Pharmacist Day on the 25th of September. We were set up with a head office in the Netherlands, and we always stand on the shoulders of giants. Our Dutch member organisation was fundamental in founding FIP. For a while there, we shared offices with them. We do represent pharmacy. We represent pharmacists, pharmaceutical scientists, and pharmacy educators. We've got, that number needs to be updated because we had some more member organisations entering FIP at council this week. But we have got membership across all 6 WHO regions through our member organisations. Also, we have academic institutions, schools of pharmacy as members, and then we have the individuals. And the individuals who are our officers and our volunteers are the lifeblood of FIP. They really are the people who enable us. They are the ones who turn the lights on when FIP is in the room. But most importantly, the big grown-up conversation is none of us can do anything on our own. I think there's a phrase, isn't there, that you can run fast on your own, but you can run longer if you're in a team. So it's through partnerships and extensive collaborations that we do better, whether it's member organisation with member organisation, whether it's professions working together, whether it's us working with our collaborators such as Pfizer. It's really important to forge collaborations because when you're on the same page, you can really make a difference more quickly. And I think we're all over the idea that we might have to test and prove and pilot things. But if we know they work in one country, let's take that as a proof of concept. It's really important. It's a very sobering week for us when we look at the United Nations General Assembly last week to track progress against the Sustainable Development Goals and find halfway through the time span to 2030, we're not doing well enough. So the only way we're going to do well enough is if we collaborate. And most of you know, I'm an Irish national, and we have an anthem that has shoulder to shoulder. And that's a phrase I use all the time because we all understand if we stand shoulder to shoulder, we're going to go further. I've mentioned our vision, and I've mentioned our mission. I took over this position in 2018, and in October that year, we signed pharmacy up to the Astana Declaration. Those of you who don't know what the Astana Declaration is, it was the 40th anniversary of the Alma Ata that was published in 1978. And the 40th anniversary gave us a bit of a moment to reflect on the progress in primary healthcare. We've done a lot in our developing or high-income countries to reduce infant mortality, to reduce death by communicable diseases, but then we have all sorts of other chronic morbidities, exactly, elderly populations that are getting frailer. We've got to think about how we manage all of that. So the report card was good in some areas, but could do better. So we took our pen and we signed the profession up and we aligned our work accordingly. Then, of course, in 2019, the WHO issued its 5-year strategic plan. We are in an official relations with WHO, and that has been in place since the WHO was formed in 1948. But this plan and the Astana Declaration afforded us an opportunity to align even bigger, even better. If you align at a global-to-global level, that means we can give you the toolkits to have conversations with your health ministers in your country with examples of best practice so they can open the locks. The plan here was the $3 billion target, ensuring 1 billion more people benefit from access to universal health coverage, 1 billion more people are protected from health emergencies, and 1 billion more people enjoy better health and well-being. And you see here, 2019, the global threats. I'll just leave you to ponder that and think, does it feel like we're doing better against those threats in 2023 than in 2019? Of course now, hindsight is a valuable piece, but it wasn't so much that we had a global influenza pandemic, we had a global COVID pandemic. And as many of my colleagues in the global south would say, thank goodness it wasn't anything worse than COVID, because we have other pandemics bubbling along under the radar, so to speak. But on every single one of these, it feels to me like the volume knob is up a little bit. Air pollution, climate change, NCDs, pandemics, fragile and vulnerable settings. And we had a humanitarian plenary this morning. Startling even to look at since Seville. And in Seville, we were looking at wars and famines and climate change-induced crises, Ukraine being an example. And even in the last 3 weeks, we've had Morocco and Libya with massive climate change-induced troubles. And that makes your fragile settings maybe more fragile from COVID, absolutely unable to respond to an emergency. AMR, Ebola, weak primary healthcare, again without investment in a workforce or systems or sustainable services. Vaccine hesitancy, I have no absolute proof, but I feel like those of us who are not vaccine hesitant are even less vaccine hesitant. So we've moved up the scale, but we were there anyway. And those that had hesitancy seem to have been pushed even more hesitant. And that's something in our politics we really need to be able to manage. And then dengue and HIV. So alignment then. In 2020, we published our development goals. They built on our workforce development goals, direct alignment here. And our strategic plan takes us to next year, and then of course we're doing 25 to 2030. So you see we are aligned with where we're headed. The recent materials and resources. Remember I said you've got to have almost like the cupboard of how to do things. And in there we've got toolkits, advocacy toolkits, enabling toolkits. We've got various slide decks and resources. We've got digital events. We've got bibliographies. We've got policy statements. We've got education through partnerships. And then we've got our position statements. And FIP calls policies statements, and what we do is that we publish a statement that has been developed by a multi-agency, multinational group, and that then gets approved on our council. And I'm really delighted to say that on Sunday this week, we approved our policy statement, Global Policy on Life Course Immunisation. And from that, we will develop regional toolkits, and from that, we will develop national enablers. So you could say it's all coming together. And then, of course, the pandemic was a dreadful time for everyone, a dreadful time. But in these times where we seem to have the big global crises that no one country can manage on its own, it's worth looking at the silver linings. And the silver linings in this is to look at the opportunities for paradigm shift that the pandemic brought us. And I would say we're still learning that. Now, we published our pandemic preparedness report on the 4th anniversary of Astana, 25th of October last year, and that really mapped out the 1,000 days living with COVID. We started from the 30th of January 2020, day one, and then we measured it in blocks of 100 days to see what we were doing when. And I just have to say, colleagues, you should take your hand and pat yourselves on the back, because we've almost forgotten how every day, every week, every month, things were changing so fast, and all of us were doing it from our homes if we were lucky enough to be able to. And may I just pay a really big tribute to the pharmacists out there on the front line who kept the lights on. You kept the systems running and working, be you in hospital or community. That is something to be very proud of. So pre-pandemic, we had adult vaccination rates for vaccine-preventable respiratory diseases stubbornly low. As we've heard, we focus on our babies and infants, which is absolutely appropriate. Children, of course you've got to keep them healthy. But actually, our aging populations also need some help to bolster themselves through frailty. So it's been a long-time question of ours. Why do we accept lower rates for adult vaccinations? Why is that just even a thing? Heightened rates for older adults and vulnerable populations, and the knock-on impact on health systems when you have a vulnerable population that is not as vaccinated, not as protected as they could be. The impact that has on their non-communicable diseases, their ability to function, their ability to live at home well and safe, is massive. And that also has knock-on effects on the health systems in a country. So the emphasis was really on the matter at hand, COVID-19. But actually, it really got us thinking, all of us, in all our agencies, to other vaccine-preventable diseases, especially respiratory, like pneumococcal pneumonia and influenza. And it was really important for us to use the data that came out of the pandemic to prove that adults will come out to get vaccinated. So then today, we've got to think about, as a result, we are in, the times have changed. You know, they really have shifted. We're not back to 2020. We've gone through that trauma and we're out the other side. And it has shifted the paradigm. There's a need for higher rates of adult vaccination against certain respiratory diseases. There is just a need. It's proof. It's got to be there. And that will help protect individuals, their families, health systems, and economies. And we've got a workforce symposium going on in parallel here. And one of the things that came out from the WHO speaker in that was the conflict between thinking that we spend money on our health services rather than invest money in our health services so that we have a bigger economy. Investing in health leads to growth. I'd really like to meet the economist who could make that work in all our systems. So now we really need to think about vaccination at all stages of life, all stages of health system capacity, and also expand it to meet the needs of public health worldwide. And at FIP, we have a mantra where you adopt and adapt. So in one country, it might have a different set of vaccination profiles. In your country, lift that and adapt it to your needs. So it's not a direct copy-paste. You can see here the different steps that might be needed. We know that we've got advocacy programs in place, we've got patients to be identified, we've got a role to educate and recommend, and then we've got the administration and the prescription. And all of these form part of our vaccination toolkit this year. You will see very, very small print. We can provide you with the links afterwards of where you can access these toolkits. And there's a wealth of evidence now around the impact on the role of pharmacists in the pandemic. It was a really big global health crisis, but it's led to further global health crises. We've got an iceberg of health need that was frozen at the point of the pandemic, but is slowly bubbling up to the surface, sometimes very quickly actually. And we also have our workforce who's also impacted. But if you think about the crisis giving frontline pharmacy the opportunity to demonstrate these services are valuable, not only to the individuals but to the systems, and that they are feasible and that they are ready to be implemented, it seems like a no-brainer that our governments would come on board. And there are these elements here that you could think to pick up and adapt for your own practices, potentially. The administration for other respiratory diseases, expanding those population groups, maybe even thinking about repeat dispensing of medicines around all of this. So to fit your systems of dispensing around all of this is really important. Where is the place of home delivery of medicines supplemented with telepharmacy, for example? And then there's point-of-care testing for screening. And pharmacy and pharmacists are interwoven into all of these areas. So when we say never before have the demands on pharmacy been so great, we can also see this is an advocacy role for us to be part of the solution. Pharmacists are making a significant impact on vaccinations. We would recommend that they are available in every market to offer complementary capacity. This slide shows in sharp focus the different nations where adult pneumococcal vaccinations across the different countries are available. And if they are available in those countries and those countries are similar in terms of health systems or in terms of patient need to your own countries, the adopt and adapt is really helpful. And we would say that is what has accelerated the uptake of these in so fast speed. We're now at 48 countries and territories with pharmacy-based vaccinations. Since 2020, we've got Algeria, Belgium, Germany, Italy, Jordan, Latvia, Lithuania, Poland, Romania, Saudi Arabia, Tunisia, and UAE. And of course, we should be at 100 soon, and then we should be at 150, all the way up to the 195. But we have made great progress. The other piece to think is to look deeply into one country to see how that has accelerated or how that has developed over time. And we thought we'd take a look at France as one example. And the reason why we're taking a look at France as opposed to any other country is that you will see that the role of the pharmacist in 2017 in this area was markedly less than today. So we start out in 2018 seeing influenza being piloted across 4 regions in the country. 2019, we've got influenza at a national level. 2021, in the middle of the pandemic, we've actually got influenza and COVID on a national level. 2022, that's not enough. We then see administration of other vaccines at a national level. And then we move into this year where we see prescription of other vaccines at a national level. So of course, France may not be exactly the same as every other country out there, but this should illustrate to you, you can start from small coverage and you can layer on, year by year, different services until you get to where France is at in 2023. If we could make this as the roadmap for a country, I think we would start to see that 48 become 96, become 148 again. In January 2022, this was all switched to a different level in France. There was a new paradigm for pharmacy vaccination. On January the 27th of that year, the HAS, the French High Authority for Health, issued a recommendation enabling pharmacists in France to administer and prescribe non-living vaccines to patients over 16 years of age. There was an exclusion around immunocompromised patients in that area, and I think pharmacists would be very happy with that because that's a high-risk group, and in the pharmacy there may not be the facilities there for that type of patient. But then it's grown and grown throughout 2022, passed in legislation, and now it's established so that pharmacists in France can administer non-live vaccines to patients over 16 years of age. And when we say non-live vaccines, look at the list here of the types. There's influenza, pneumococcus, pertussis, diphtheria, papillomavirus, hepatitis A and B, meningococcal, and rabies. So it's a big portfolio of vaccination. How was it all started? So in FIP, we've got toolkits that take you, let's say, from A to Z. You might have letters to ministers, you might have the evidence-based, you might have a toolkit, you might have an enabler, you might have a digital event. Some countries want ABC, some countries want JFK. In 2016, the National Order of Pharmacists, one of our FIP member organisations, proposed a 3-year pilot initiative of pharmacist-administered adult influenza vaccine. A leap of faith, you might think. In 2017, 2 regions took it up and participated in this influenza pilot. And at that point, you start to see 156,000 customers were vaccinated in nearly 3,000 pharmacies across these pilot regions. Gathering data as you go, gathering data as you go. In 2018, the pilot was expanded. So you have trust, your government trusts you, they see the data, they see this is growing, and they want to support you to open this up even further. At this point, we've got 737,000 customers vaccinated, with nearly 170,000 of these being vaccinated for the first time with flu. In 2019 then, you see further trust from the enablers, the governors, the policymakers. The social insurance budget law allowed pharmacists at a national scale to administer flu vaccinations to anyone in the groups for which treatment is recommended. 2 pauses for thought here. We have a global pharmaceutical observatory where we gather data from countries. We're about to publish a big workforce report, which tracks now 15 years of workforce trends across the globe. But this is really important for us to not only take a country as a case study, but also to look at the data they've collected and to ensure that other countries collect that data too. Suddenly, you start to see an exponential rise in this. Of course, we've got COVID in the middle, and in March 2021, the French government introduced legislation permitting pharmacists to prescribe and administer all approved COVID-19 vaccines. What we saw then was, in an emergency, the profession could be switched on to administer COVID because of all the steps that had happened before. So I would suggest that we need to put steps in place in each country to manage the vaccinations that are needed now, and then as and when emergencies come, we're ready. October 2021, HAS published recommendation allowing pharmacy technicians to administer flu vaccines. Now we know that won't work in every single country. Some countries don't have pharmacy technicians as a cadre in their workforce. What this means is you're increasing the capacity in your workforce by enabling that cadre, that group, to be part of the vaccination process. In Jan 22, the French government published a decree authorising pharmacists, nurses and midwives to prescribe and administer the COVID-19 vaccine to children between 5 and 11. So you start to see the capacity being grown with other healthcare professions and with other patient groups. And then at the beginning, in the same month, the HAS published a recommendation allowing all nurses, pharmacists and midwives. Literally within the same month, we had not only moving to COVID-19 for children, but then also to prescribe and administer non-live vaccines on the vaccination schedule in people aged 16 and older. So we say leaps of faith, don't we? The government took a leap of faith in the French pharmacists. Actually, they didn't. They looked at all of the evidence of delivery, evidence of impact, evidence of benefit. We also then saw COVID-19 pandemic rapidly accelerated policy changes to expand pharmacist roles. And during the pandemic, French pharmacists administered high volumes of COVID-19 influenza vaccines. This provided complementary capacity to public vaccination services and freed up healthcare system capacity. This is a really big point for our other healthcare professions. We're not taking patients from them when we open up pharmacists to vaccinate. We're actually vaccinating additional communities and groups of patients, and that leads to a healthier society. And you'll see here on the slide, 26 million is the total number of COVID vaccines administered by pharmacists. 63% of COVID vaccines were administered in pharmacies. Nearly 90% of all pharmacies in France had staff who were authorised to administer. You've got the capacity there and the capability. 98% of French people who've been vaccinated in pharmacy say they are satisfied with the experience. And 41% of influenza vaccines were carried out in pharmacies during 2021-2022. Progress has been made. Since 2020, the number of countries and territories where pharmacy has gained authority has grown hugely, massively. But also what we see with our healthcare systems fragile and overwrought, and with the iceberg of need coming to the surface, you're also seeing problems if we do not protect that capacity. Beyond the pandemic, the pace of advocacy, legislative and regulatory efforts to support has slowed down. So it's up to organisations like FIP to work with advocacy organisations in nation to keep the momentum up. Significant policy changes have been seen in countries beyond France, such as Italy. And this is a timeline. I won't read it all out to you, you can see. It's a similar story, but with different accelerations and decelerations. So starting out in 2020, pharmacists are unable to vaccinate. 21, COVID vaccines can be administered in pharmacies. That's January. March, pharmacists are permitted to administer without doctor supervision. June of that year, pharmacists begin administering COVID vaccines. September of that year, pharmacists are permitted to administer influenza vaccines. And you might say, why at the beginning of 2020 were pharmacists not able to, and literally within 18 months or so they are? And the answer is, stories from other nations with evidence will persuade and enable and empower another country to learn and implement. There's a list of references here which we think are really important for you to know that the sources that we're using are credible. But additionally, colleagues, we shouldn't only leave our policy changes to evidence only, or evidence with meta-analyses and randomized controlled trial. We need to measure what we're doing, and that contributes to the bigger picture. And now I'm going to hand over to my colleague, Professor Lisa Nissen, for the next part of the story. Thank you.
Thank you, Catherine and Sandy. Tough acts to follow. And nice to be able to come along with a case study locally from Australia. I'd like to start just by acknowledging traditional custodians of the lands we're meeting on here, the Yagara and the Turrbal people. And I think to acknowledge also that they were the first pharmacists and healers in our country and contributing to the outcomes for their communities for centuries. It was great having Catherine's introduction about the journey of pharmacists in this space around vaccination, and I think some key messages from both of the presentations were about the evidence that you can use from other countries and the examples that you can take to the table around those experiences. It's been great to be able to contribute to some of the toolkits and resources that FIP have available, and those are great resources to use within various settings, policy settings and political opportunities that might become available. I'm hoping that I can use our example here from Australia as part of that. And I think two other things, from little things, big things grow, I think is a good example of that as well. And the third point is that pharmacists should be everywhere that there's a medicine, regardless of whether that's at a regulatory space or at the patient coalface. My opportunity is to talk a little bit about a case study of Australia and the opportunity to use policy windows. We sometimes, I think, look to line up every single duck before we think that we've got an opportunity to move forward. And I think Catherine's already highlighted some beautiful examples where the pandemic has been a great lever for different countries and different practice settings to push forward into the vaccination space. There's been a rapid acceleration of some countries coming on board because of the opportunity around workforce and the need to vaccinate. Some other journeys have been slower, and it's been a case of gathering evidence, showing what other overseas countries have done. And I'm hoping that we can use an example that's now feels like a short time ago, but it was actually the beginning of our vaccination journey here in Australia. So I wanted to talk about the Queensland pharmacy immunisation pilot. So started literally about 500 metres from here in an office space where we were asked to implement vaccination for pharmacists in Queensland. So at the time, some of the policy drivers here was that we had a chief health officer that was very passionate about increasing vaccination rates in the community. As we've talked about, there's been an interest in childhood vaccination, but we had a state vaccination policy that was looking at how we could look at some of that adult vaccination rate and how we were unable to reach into the community as well as we'd wanted around adult vaccination rates. So we wanted to increase some of that, and she was very interested in how pharmacists and their accessibility in the community could be used as a lever. We'd also had some experience of some other sort of pandemics. Certainly nothing like we were going to experience. Maybe she's a bit of Nostradamus, Jeanette Young, but she knew that there would be more pandemics. And the ones that she had experience of in her chief health officer role, she knew that pharmacists had been able to lean in and assist in other ways around supply and procurement of medicines and distribution, but knew that they could do more. So she knew that there was also experience in other countries, and again this comes to where there's exemplars from other countries of people that are already doing these roles safely and effectively, and that we could lever off those opportunities. But what we needed to do was talk about what the gaps were and how we needed to upskill our workforce. So what Jeanette also knew, or Dr. Young also knew, she's now our governor in Queensland, was that pharmacy did have a gap in what we could bring to the table, and it was about some of the skills and training that we did in our current pharmacy programs. We didn't teach people to administer vaccines. She knew that we knew a lot about cold chain, she knew that we knew a lot about vaccinations and vaccines themselves, but we needed to identify and design or investigate what kind of training we would need to uplift the pharmacy profession to become vaccinators. So around appropriate and safe administration of vaccines and really managing the consequence of giving vaccines in community pharmacy settings where you may have declining patients or you may have people having an adverse consequence to the administration of those vaccines. So we needed to put forward that sort of space around the identification of that program and what it might look like, and design that program to implement a pilot around rolling out vaccination. So what was the gap? So we worked with the accreditation agency for pharmacy in Australia, so our Australian Pharmacy Council. We worked with the professional organisations in Australia at the Pharmacy Guild and the Society in Queensland to look at what that training might look like. And we looked at the national immunisation competencies for other health professionals. Because when we were looking at this opportunity, we wanted to say, well, what do you expect other people to be able to do? It wasn't saying that we were going to do something different for pharmacists. We wanted to say, well, we just want to do what other people are expected to do. So we used those competencies, we looked at our pharmacy competencies, and we were going to address whatever gap was required. Now, if you look over onto the right-hand side of your screen, we now train our undergraduates to vaccinate as well. So people will leave our universities as vaccinators. But at the time, it was about uplifting the current profession to be able to vaccinate. So we were given 3 months to implement all of this, because they always give you lots of time. Not unlike some of the exemplars that Catherine showed. And so over a period of a couple of years, we were tasked to implement this program. The first tranche was with 50 pharmacies, and then we shifted to 250. But you can see just over that short period of time from 1 year to the following year, we went from influenza to influenza plus MMR and DTP. Because immediately there was an observed opportunity to increase the range of vaccines that we could administer and the scope of the program because it was so successful. And I think the important things that have already been highlighted were that people who hadn't been vaccinated before were vaccinated for the first time because it was easier to get it in the pharmacy, it was accessible, it was acceptable for them to have it in that area. Even if they were eligible for free vaccines from other providers, they were happy to pay to get it at the pharmacy because it was easy for them to do. They trusted the pharmacist, and it was at a time that was suitable for them. So the department were very happy to support that, and what we were able to do was have that then become a scope of practice for pharmacists from that point on in Queensland. What we then found once the pandemic hit, and I'll talk more about the broader timeline that rolled on from the pilot, was that pharmacists went on to administer millions of COVID vaccines in Queensland. So Jeanette was doing a bit of this. I told you so. And they became a major contributor to the COVID response in Australia, and in fact at this point in time administer the majority of COVID vaccines in this country to this day, and millions of influenza vaccines among other vaccinations. So successfully administering COVID vaccines, and in Queensland we were the first pharmacists to administer COVID vaccines in this country. So the timeline that's really relevant for this is you can see starting over on the far side, we had the first pilot was in Queensland, but very rapidly we had a domino effect across the country. So we were able to, because we're a federation, so each state has its own health department and regulatory system. Each state then started to use the evidence from the Queensland pilot to push the departments in their own state to roll out that change across the country. And so you can see we went from the Queensland pilot over on the far side to Western Australia picking up the pilot, to our second phase, to New South Wales picking up the pilot, to Victoria, Tasmania picking it up, and by the time we got over to the COVID pandemic, we had a large range of vaccines available across the country. And now when we come over to the far side, we have pharmacists able to administer vaccines down to 6 months of age across some of the jurisdictions, and our national immunisation program vaccines funded and available across the country, and that's rolling out in the beginning of next year. So we've gone from sort of zero to hero in what would have been now a 10-year period across the whole country by starting with a snowball effect of evidence and policy windows accelerated by the COVID pandemic. So I think some of the key lessons that I would pass on would be that we had the opportunity to take, I think, a patient and a system focus rather than coming in and saying pharmacists want to do this because it's a pharmacy thing. It's about addressing that public health need and the patient need. So it was policy-led reform that was the opportunity for us. And I think that is the thing that is a great lever for any of the opportunities around scope of practice and contribution in public health and other areas of practice. We shouldn't be reinventing the wheel. We should be using data and training that other professions do, and we shouldn't be looking at doing things that are different. We should be looking at saying we want to be judged and treated the same as other professions. Demonstrating working models is successful in other countries, and what we've learnt here, at least in our country, is that jurisdictions or states are competitive. And if Queensland's got something or New South Wales has got something, they don't kind of like that. They like to think that they're at least the same or better. So you can use that to trade off against each other. You can change regulation and legislation. I think we saw more than ever in COVID that you can change things overnight if you really want to. So that whole argument that you can't change things because it's too hard is not true. People will pay if they value a service as well. So waiting to get things funded as a way of changing things. If people value it, they will pay for pharmacist service and contributions in the community. And I think the fact that we don't always put forward that we're clinicians within clinical teams, I think we're kind of the ghosts that walk behind, I think, a lot of health and healthcare and public health particularly. And I think using those competencies is really important. So I think health and healthcare and workforce reform is being very driven from a patient and service need perspective. And I think this is very much the view that we need to be looking at now as pharmacists and our participation in health teams, and that focus that it's about skills and knowledge and how we bring that to the team and the system will be really important. So what is it as pharmacists and people that have contributions around medicines and medicines use that we can bring to catalyse health workforce and the contributions to health and healthcare? Because this is going to be the really important model of care that is going to be used in workforce reform and building the system differently. And some of this is a long game for different jurisdictions. We have kind of gone over a 10-year period from influenza to everything. Others have taken a couple of years to do that same journey because of different levers. Sometimes you have to eat the elephant slowly, but if you keep patients and the system as the focus, you will be able to get there in the end. Thank you. And I'd like to hand it back to Sandy.
Okay, twice up, still not tripped. I am going to go through very quickly because I want to make sure we have plenty of time for Professor Moore. Just a quick overview of the U.S. pharmacy system. So I think we're all pretty well acquainted with the fact that the U.S. vaccination, or pharmacists as vaccinators, is a pretty well-oiled machine at this point, but this took 30 years. And I think that can't be underestimated. Starting on this slide anyway, we see 1994, but that's not when things began. I mean, this started before that. Progressing through to 2009, when all 50 states allowed authorization of vaccine administration by pharmacists. And I think importantly, now what we see in 2016 is that all ACPE accredited schools of pharmacy require inclusion of vaccination training in their curricula. I mean, you can't ignore that you need to socialize this early with all of pharmacists in training. I'm really not going to go through this because I do want to go through this quickly, but you see that we're seeing more of an extended scope of practice as far as which vaccines are allowed. One thing that's missing here, though, is if you limit what pharmacists can do, you're really not benefiting, or you're not sort of obtaining your full potential to impact public health. So although we've seen more, there's still a dichotomy in the US where some states allow things and others don't. And so we really don't have that full scope of all vaccines, what you see in some other countries, because we have 50 states which operate as 50 different countries sometimes, oftentimes. As with other countries, in the US, pharmacists are seen as highly accessible, trusted, and highly skilled professionals and are in place to support immunization systems. The one thing I want to highlight here, we have plenty of evidence to support the visions of accessibility, the trusted professional, as well as the skilled professional. But when you look at accessibility, you see that, and any of you who have visited the States or live in the States know this to be true, approximately 90% of people live within a 5-mile radius of a pharmacy. But I think what's even more important is what you see down below, that there are approximately 15% more pharmacies locations within low-income communities compared to physician offices. I mean, we really know that we have a problem with underserved communities, and the fact that we have more pharmacies available to help service these communities is huge. With the COVID-19 pandemic, as we saw across the globe, there was an impact on the ability to expand pharmacy vaccination services. And here you see that we had legislation at the federal level, which normally doesn't happen, that allowed pharmacists, and this happened in 2020 at the beginning of the pandemic, allowed pharmacists to administer routine vaccinations to individuals 3 to 18 years of age. There was a need, there was a gap, and pharmacists were deployed to help fill that gap, because we saw that as the pharmacies stayed open, the physician practices were not, and they were doing a lot of telemedicine, and you obviously cannot vaccinate via telemedicine. So there was a gap that was filled. And this continued through in 2020 to include long-term care programs to help pharmacists support administration of COVID-19 vaccines in long-term care facilities and other residential care facilities. And then in 2021, Health and Human Services introduced emergency legislation to allow qualified pharmacy technicians and interns to administer seasonal influenza vaccines, again, to help fill a gap to adults in the states where they were licensed, so similar to what we've seen in other countries. I think I'm going to skip this slide in the essence of time, but one thing I will point out is that pharmacists are making not only an impact in the US with regard to administering COVID-19 vaccines, but also other vaccines against vaccine-preventable respiratory diseases. So you see the numbers for influenza as well as pneumococcal, where approximately 40 to 50% of adult vaccination occurs in community pharmacies. I really like this slide because this is kind of, in a sense, the money slide, because it shows what the impact has been. And a 2022 study showed and estimated that in the US alone, pandemic interventions by pharmacists and their teams averted over 1 million deaths. That's huge. Approximately 8 million hospitalizations, as well as, when your ministers of health want to see how you've impacted the bottom line, $450 billion in healthcare costs. So the contribution to pharmacists to immunization can obviously allow easier access to vaccines for adults, but also helps protect those populations and help improve public health. And we've seen this slide before, but I will reiterate the 4 R's of recommend, repeat, remind, and review. We know vaccines are effective tools for supporting older adults as their immune function continues to decline throughout the aging process. And as a pharmacist, you are one of your patient's best advocates for health and supporting them to stay healthy as long as possible and to preserve the quality of life. So I did that very quickly so that we could keep going. And at this point, I'm going to now turn it over to Professor Michael Moore.
Thanks, Sandy, and you can see my disclosure there. I think it's really important to just keep in mind the notion of the fact that we are at suboptimal vaccination rates for older adults. And I think one of the problems that we're dealing with is that although we have very clear vaccination schedules for young people, it's not so clear in terms of our vaccination schedules that go across the whole of the lifespan. And that should include, as it does, for example, in Australia, the reminders that go out to parents for their children's vaccination. And we've started that process with adults, so those who are as old as me will have had a reminder to have your shingles vaccine. But it doesn't happen right across the schedule, right across the life course. And I think it's an important thing to remember. So when we look at the graph here and we look at the disparity in the COVID-19 primary dose vaccine uptake rates for over 60s and the influenza uptake rate in over 65s in European countries, you can see that we are still really at suboptimal rates. And that applies, of course, for vaccine-preventable respiratory diseases. We know that vaccination has a significant impact on economic burden. And we learnt many things through COVID, but one of the most important ones from my perspective was that people actually began to understand what public health means. It's not just public hospitals, but public health is something that's political, it's economic, as well as health. And the bottom line and the way it works is in influencing is important. And Sandy mentioned when the minister gets the information that so much has been saved, it's not that that helps the minister make the decision, that helps the minister influence Treasury and influence in the cabinet or however the system works. And so when you look at this particular example from Europe that you've had a chance to read, look at think of the economic and productivity impact on over 700,000 less physician visits, over 1 million working days lost, and the cost of hospitalisations, and then of course the impact of death, which is the final stage in what we're talking about. So what's the role of pharmacists here? How does it fit into the broader picture? Well, a pharmacy isn't a particular community pharmacy isn't an enabling environment, and it's that enabling environment that helps to encourage people to ensure their vaccination. And then, of course, the social influence. Why the social influence? Well, because pharmacists are so respected. Now, I have been a politician. I know what it's like to have the respect level of a politician. We didn't rate that highly. And then compare that to the level of a doctor or a pharmacist. And so the influence that you have is actually often much greater. And when I'm talking about influence, I'm not just talking about influence politically, although that is very important, but it's also the influence you have with the individual who comes into the pharmacy or who you're dealing with in the pharmacy context. And also, of course, motivation that you can provide, because it's understand that you actually know what you're talking about when it comes to medicines, to vaccination in particular. So what are pharmacists? And this in some ways reiterating what the former speakers have said. But identifiers, educators, vaccinators, identifying at-risk patients or identifying patients who it's time for their next vaccination or it's time for a particular vaccination. And remembering you're also identifying the fact that it's accessible for people. And educators, you're providing guidance about vaccination and dealing with the myths, so many myths around in the social media that you do have answers for. And you can address those specific beliefs and concerns. And that part of the reason for that is so often you have quite a long-term relationship with the individuals who come into your pharmacy, just as I have a long-term relationship with Andrew, who's my pharmacist. We are talking about highly trained healthcare professionals, and people are understanding, I think particularly since COVID-19, that the term public health professionals is a very, very broad term, and one that is focused on improving population health outcomes. Let me just mention that the Johns Hopkins University has as its platform about public health and public health professionals that we save lives 1 million at a time. And it's a really interesting way of framing public health and public health professionals, and that when I talk public health professionals, I talk about a full range of people, from the epidemiologists through to pharmacists, through to specific doctors, specialists, and those who are involved politically. So I have this little slide to encourage you when you are thinking advocacy, and now I'm talking about political advocacy, about influencing government. Remember that the first and most important thing is establishing some sense of urgency. Why a sense of urgency? Because ministers are incredibly busy people, and if it's not urgent, it's going to go on the back burner. So that sense of urgency is incredibly important. And as I think a number of our other speakers, and particularly Catherine, mentioned, you don't do it on your own. And that's why it is that I'm part of the Immunisation for All Ages group on behalf of the World Federation of Public Health Associations. FIP is part of the same organisation, the International Federation on Ageing, because we work together, because we know that we can have greater influence in that way. And it's influence is what it's about, and it's about maintaining influential relationships. And don't forget, at a personal level within a pharmacy and pharmacy relationship, that relationship is a fundamental way of influencing, because those relationships are built around trust. And it's trust that is the fundamental in what we're talking about. But there's no point going to a political party, a politician, a government member, if you don't know what it is that you're going to ask. And you've got to ask very, very specifically about your change vision. And that's why Catherine was talking about going through the governing council. I'm not using the exact right term, but the council approving a vision for where we need to be going for vaccination. And by the way, it's a vision that is shared almost, not quite word for word, but certainly in concept with the World Federation of Public Health Associations. And then you have to be able to communicate that vision to buy. And then you want to bring other people with you. And that's done in a myriad of ways, saying, well, we have this policy, do you agree? Would you be prepared to support it? We often go out to academics and ask them, would they support that sort of thing? Now, these are actually a sequential group of things, with the exception of this one. It's about being opportunistic. We talk about an elevator pitch. We talk about standing next to a minister in a football game because the kid happens to be playing at the same time as yours, and being able to just build that relationship, say a few words, hopefully get a meeting away from that context because you are engaging. And don't forget of the importance of achieving short-term wins. You know, so many times I hear people say, yeah, but politicians are only interested in the next election. Actually, almost every politician I've ever met actually wants to believe they have a long-term vision. Some actually do. But what they actually need to do to implement that long-term vision is to make sure they have something to sell at the next election, whether it's been putting money into something that focuses on output rather than outcome. And then we've heard about the 4 R's and how important they are. Professor Rob Moody at the University of Melbourne, a public health professor, talks about the 3 P's of advocacy: persistence, persistence, and persistence. So we never let up, we keep it going, and then we incorporate those changes into culture. And we can see from all the previous speakers the importance of doing just that, and we can see that vaccination is now incorporated into pharmacy. How do we expand it? Depending on our country and so forth. That, of course, is a challenge for us. But the reality is that pharmacists, like other medical professionals, are really trusted sources of information and are trusted advocates, and they can use this to influence government. And I would encourage you to do just that. Thank you very much. And I'll now hand over to Sandy to conduct the Q&A.
So we're going to open this up now for questions with our speakers. If you'd like to ask a question, please raise your hand and we'll get a microphone to you.
Thank you. Jo Barnes, University of Auckland in New Zealand. I'd like to thank all of our speakers for really excellent presentations. Thank you. My question is around, there's another really important public health role that pharmacists have here, and it sits alongside the vaccination programme, and it's pharmacovigilance. So pharmacovigilance is a really key public health function. So I wonder if our panel could comment on the role of the pharmacist here in pharmacovigilance, and whether actually there should be a fifth R, Cassandra, on your list, and that's R for report. Pharmacists reporting adverse events following vaccination and encouraging patients to report as well. Thanks.
Okay, I think it's on. Okay, that's a terrific point, and I'm going to see who on the panel would like to tackle that first. Lisa?
Thank you. I'll go first, but I'm sure there's others who want to chime in. I think that's really important, and I think that's a great opportunity that pharmacy has, not only I think if we look at the whole cycle of our engagement in the medicine space, we get an opportunity, I think as Michael pointed out, to have that long-term engagement and relationship with people coming back to see us, and that review part of medicine's use and are medicines working, but also have there been any consequences of medicine's use. And I think during the pandemic and also the space around vaccination, I mean, we had a particular opportunity to look at the optics around the impact of COVID vaccines, and there was a lot of concern in the community around what were the short-term, but some of the emerging longer-term consequences of COVID vaccines, and that also influenced, I think, that space around hesitancy. I think, Catherine, you spoke to that place where some people moved that way with vaccination, but people actually ran in the other direction because of that. So I think it's incredibly important, and I think some of our documentation systems, the way that we record what we do, some of the way that we engage with some of the shared software systems, how that we may have information about patient interactions and information about medicines, and how we share those accurately, and how we report adverse events, will improve some of that way that we can engage in the pharmacovigilance space. But yes, we absolutely have a role, particularly where vaccination is concerned generally.
I mentioned that trust was so important, and if we're not being open and frank about adverse events, then we're going to lose trust. And what you measure and is done accurately, and the data you use becomes absolutely fundamental. So in short, the answer is yes.
Thank you, Jo, so much. That's a really good question. And you've mentioned about hesitancy. I think there's something we're going to have to do a little bit in the back room about how we communicate to patients and the public. There's a concept out there in many, and we know this from our families, that when something happens to you with a medicine or a vaccine, that's because there's a problem with the vaccine. It's been made wrong, or it hasn't got enough evidence, or. This whole thing, we really need to work our way through. We need to be more, I suppose, more open and transparent when we get the language right about the notion of risk and evidence, and the fact that we use medicines without the full evidence, because the full evidence only comes out when we're using medicines. And that patients need to understand as well that not medicines come with side effects, and that nothing makes you perfectly better at the end of it. I even listen to my family, and I hear them saying, well, my cousin, she ended up with arthritis because of the COVID vaccine, and therefore I'm not going to have it, as opposed to, can we talk about why that could probably have been exacerbated? So there's the reporting piece that we should get the vast majority of people involved in, and that they can understand that that is part of their role in the medicine cycle. But also to really understand that if we start saying report the errors and report the risks, that could turn the turned off even more off. And that's a big worry. I'm really worried, actually, if I'm honest with you, about every bit of anti-communication I see now that, you know, without going off on one, but when people get accused of something that they've done wrong, suddenly that escalates into a government conspiracy and that the whole world is against us. That language is really troubling to me. So as scientists, I think we need to gather our thoughts in a way that is concise, not defensive, but also very certain. I feel that sometimes was lost in the pandemic, and that where we didn't have the evidence, that was evidence that it didn't work, if that makes sense, colleagues. So I think this is a really important piece, but it can't just go about with that here we can use reporting, because I think that will fuel the conspiracy theorists, I think. But yes, it's massive.
Do we have any other questions? We have one over here, Diane. Oh, she's going. Not going. I was almost tempted.
My name's Kim. I'm the infectious diseases pharmacist here at Royal Brisbane Hospital, and Lisa's waving because we've worked together. Thank you for those really excellent presentations. There's been lots of discussions around community pharmacies and pharmacists being, good access for vaccine administration in the community. What are your thoughts on hospital pharmacists, providing vaccines, improving accessibility, and are there going to be future trials looking at expanding this service in hospitals and for hospital pharmacists?
Yeah, I'm going to give it to you. I'm glad you mentioned this, because as I was speaking, I thought I'm focusing so much on community pharmacy that I'm forgetting about all the other pharmacists who impact public health. But I will turn this over to my colleague Lisa to respond.
Was that a Dorothy Dix question, Kim?
Yeah, Andy put me up to it.
Yeah, Andy put you up to it, right. I would say, go back to my point that pharmacists should be wherever medicines are, and vaccination is the same. And I think Kim's had the opportunity to be involved in high-risk outpatient clinic vaccinations for exactly the conditions I think that you were pointing to in your presentation, Sandy, identifying folk, in rheumatology, cardiology, all of the really important areas where they're coming in and they haven't been vaccinated. So absolutely, I think you've got to be in the place where the people that need the vaccinations are. I think some of the challenges, have been, and this is a bugbear, anybody who knows me will know, that we think of ourselves as buildings, not as individual clinicians. So we're a community pharmacist, or we're a hospital pharmacist, or we're a GP pharmacist, or we're a ... pharmacist. So we're often identified from a regulatory, legislative point of view, or even sometimes professionally as a building. And that, I think, sometimes has been a barrier, and I think in the particular space of vaccination, sometimes in many countries, from a regulatory point of view, has meant that you can only do this in this building. And that's made it harder to engage the profession or the professional because of the space. But 100%, you should be where the high-risk patients are, and Kim and the team have done an amazing job, and in fact vaccinated the whole hospital for their workplace vaccinations for influenza in one of the years as well. So yeah, 100%.
Globally, answer yes, full stop. But I would say yes, where there is capacity, because we've even seen in the community that perhaps contracts for vaccinations have been put in place by the management, and the pharmacists in that team have become overloaded because nothing's been taken away. So I would say yes, of course, and exactly linked to high-risk patient groups, but also there's a lot for people in the hospital who are working in the hospitals to be managing as well. So this should be not on top of, but as well as with capacity. So there's some little yes, but, comma, so that you don't just drown the hospital pharmacists and drown the community pharmacists in vaccinations. Yeah.
Okay. Well, we may have have time for one quick question, and then I think we do have to wrap up.
Hello, I'm Megan. I'm an Australian pharmacist. It's a bit of a lead follow-on question, but is there anything happening in Australia about pharmacy assistants and technicians getting capacity and the legality to vaccinate?
I would love to say yes, but I think the problem that we've currently got is we've still got heaps of work to do around assistants and technicians and putting some frameworks around standardisation and support around the training frameworks for them and a national approach to that space before we'll be able to get there. But yes, 100%, because that addresses Catherine's question about how we adequately support the workforce broadly to be doing their roles. But I'm so with you, you know that, yep.
I'll just say there's a session going on upstairs. Part of it is about capacity, including the whole pharmacy workforce. Some countries have done this. There will be evidence. There will also be cost benefit. There'll also be rollout costs. There'll be opportunity costs that you could use as an evidence base to your ministers to say, here's how you grow the capacity. I would say, though, colleagues, that it's not troubling, but some of the discussions that WHO have been having, the fact they mentioned in 2018 there was a shortfall of healthcare workers for 2030 is 18 million, and then this year they've said that shortfall has narrowed, is very worrying. And what we in FIP, with our other colleagues, have been looking at is potentially substitution of workforces with less qualified workforces. So let's be really proud about that our pharmacy workforce do things for patients because they're qualified to do them, and we do them safely and we do them well, and we are enabled and supported. And I think that argument sits really, really well. Yeah, it's not a replacement by a cheaper cadre of a workforce somewhere, which is, there's a suspicion that might be where our governments that are all cash-strapped are kind of headed. So we will be really, really tough on this. And we sit between all the other professions on this. So I think there's something here to support them, but also they can support us with evidence as well.
One more?
Thanks very much. Nancy Waite from Canada. One thing we haven't talked about today is pharmacist access to vaccine registries. And as we move now to life course vaccination, I think we want to be part of that, an integrated healthcare system. We really need to have access to it, first of all, so that we know what vaccines patients have received, but also be able to contribute to it so that we document afterwards. And one thing I'd like to see is we do track by country, what vaccines pharmacists can give and technicians, but I'd love to see how many countries do pharmacists have access and ability to contribute to the vaccine registry piece. So just any comments on, and I know, Canada, that's been a problem, and that's been one of the limits of us moving forward in terms of vaccine, life course vaccination. You need to have that, or you create to that broken system of patients not knowing and physicians not knowing. So any comments would be great.
I think that's a universal issue, and I hear a paper coming on, but I am going to pass that down. I think we'll have Michael.
Actually, we've really only got an adult registration, proper adult registration in Australia in the last, with COVID, basically. And yes, our COVID vaccines were registered. The ones that were done by pharmacies were registered. And you remember I said you do things step by step, and I think we've taken the first step. Now we have to make sure that we keep our advocacy going to build on that and make sure that we've got a whole of life register that is easy to access and covers the full range of vaccines. And it's a really important point because decisions are made on what we know, and I think that's the important part.
Just a final point on that one. I think this comes full circle to the point Joe made right at the very beginning about reporting and recording, and that the communications around this should be about empowerment and about we know where we are when we record it, as opposed to some why is the state collecting. So let's be really purposeful with our messaging on this. But the answer would be there's no reason not to have a national register, and that is part of our global statement as well that we signed up to this weekend. Thank you.
I think that's a fantastic way to end. Want to thank our esteemed panel here. So grateful for their contributions, and to all of you for staying put throughout the whole session. Thank you very much. If anyone would love to, we would love if you would fill out